Hi, everyone. Welcome to our first webinar of the year for CalMap for the academic year 2025 to 2026. This is also the first session of our curriculum of the webinar. For our session today, the topic is on foundations of mental health, early childhood, and relational health. We're going to dive deeper on some of these early childhood elements of mental health, and then we'll also introduce the core curriculum of ours in the next following months about anxiety, ADHD, suicidality, SSRI, etc. I'm Hopi Eileen Wayne. I'm one of the child and adolescent psychiatrists at CalMap. I staff the consult line on Tuesday and Fridays, so I may have spoken to some of you, and also help organize webinars with Dr. Jeung and Dr. For those who haven't heard of us, we were previously called CAP, and now we're CalMap. We offer both consultation and care coordination, as well as free CME activities. If you have any consult questions, including after today's talk, please call us at 800-253-2103 or request it online at cal-map.org. It's cal-map.org. We provide real-time consultation that includes clinical and also personalized guidance on how to apply what's taught in today's webinars to your own patient's care. Also, as a new addition to our program, we have a synchronous webinar program too that offers 18 modules for you to watch on your demand. You can view with these recordings on your own time and answer questions afterwards. If you get a passing score for the CME questions, then you will be eligible for CME credits. And also you can check our website for more information about all of our educational offerings. There are a few more housekeeping items before we begin to introduce our speakers. Today's session is going to be recorded and it will be posted on our website for viewing after usually 2 to 3 weeks. If you have any questions during the presentation for our presenters, please feel free to use the Q&A feature on the bottom in the webinar on your Zoom view, and we'll save about 10 to 15 minutes at the end of the talk to answer these questions live. In terms of our speakers, we had the pleasure to have Dr. Gina Lewis and Dr. Jeung and Dr. today. Dr. Gina Lewis is a pediatrician providing comprehensive primary care. She serves as a director of the Resident Continuity Clinic at UCSF Benioff Children's Hospital, Oakland. She oversees training and continuity of care in the residence clinic setting. She is also honored with the Exceptional Physician Award this year. She earned her MD from Temple University and completed both her pediatric residency and chief residency at UCSF. Dr. Lewis held the presidency of California Chapter 1 of the American Academy of Pediatrics from 2013 to 2015, having previously received honors in 2005, 2012, and 2018. She's also the recipient of multiple awards for teaching excellence. Dr. Jeung and Dr. is a pediatrician who was with special training in developmental and behavioral pediatric medicine, as well as psychopharmacology. She cares for children with behavioral or developmental concerns and has strong interest in immigrant health, health equity, and trauma-informed care. Dr. Jeung has a master's degree in health and medical sciences from the University of California, Berkeley. She earned her medical degree and completed a residency in pediatrics at UCSF. She completed a research fellowship in minority health policy at Harvard and also earned a Master of Public Health degree in health management at Harvard as well. Dr. Jeung is active in the American Academy of Pediatrics, serving as an executive committee member for the AAP Council on Healthy Mental and Emotional Development, as well as a member of its council on immigrant, child, and family health, and on the AAP California Chapter 1 Mental Health Access Committee. With this, I'm going to turn it over to Dr. Lewis and Dr. Jeung.
Thank you so much. Let's go ahead and go on to the next slide here. We're going to be talking a little bit today about this framework called the Healthy Mental and Emotional Development Framework that comes from the American Academy of Pediatrics. Some closely related terms, including relational health, how this also relates to trauma-informed care. And we're going to try to make this practical, talking about some strategies that we can actually use in the office to promote relational health and healthy mental development in children, and this really exciting tool called FAN, or Facilitating Attuned Interactions, that I think will be of great help to all of us. But as we get started, let's go ahead and move on to the next slide. Get out your phones and get ready to scan this QR code. We have this little poll. So let's go on to the next slide. And I'm going to go, so scan that QR code, or you can follow those texting instructions, or I believe we can drop this poll link into the chat as well. And I'm going to start sharing my screen. How comfortable do you feel in dealing with children and families who are sharing emotionally intense concerns and or challenging behaviors during an office visit? Happens to us all. So take a moment to go onto our site. Question.
Dr. John, would you be able to unlock the poll? It says that this poll is currently locked.
Okay, let's do that. I'll stop the share and then we'll try this again.
Would you mind sharing the QR code again?
Mystique, if you could throw up the QR code for us, that would be great. Or if we can ad lib it here. Let's just start sharing that screen again. Yes, let's see. All right, this should now be unlocked and it should be ready to go. So jump onto that QR code. All right, so people are starting to jump in. So let's see how comfortable all of us are feeling. Great. So there are a lot of people here who are trying and really trying at this. Some of us loving us, some of us less so. But the important point here is that our own comfort in holding strong emotions and concerns can really make a difference in the room. I think patients can feel it, our families can feel it, and hopefully we'll come out of here today feeling just maybe a little bit more comfortable in knowing how to manage emotions like this. So I will stop my share right now and we'll go back to our regular screen. So if we could pull up the regular slideshow again. So I want to say, why are we here today? We are here because 20% of youth have a diagnosable mental health condition and another 20% have behavioral concerns that don't quite meet diagnostic criteria, but still cause a lot of distress. And about 50% of youth have faced at least one potentially traumatic early childhood experience. And I believe that many of us who are here today are seeing this in our offices all the time. We're seeing kind of at the front edge of this youth mental health crisis that we've been experiencing for a long time. And I think I'm speaking to the choir when I say that mental health is health, full stop. We cannot care for the health of children unless we are also able to deal with the mental health and behavioral concerns that come up. Helping kids to be healthy means recognizing and addressing the mental health conditions. But what if we could prevent problems before they show up? And here's where the beauty is in primary care. Long before any specialist sees them, we're seeing them. And we have this opportunity to promote healthy mental and emotional development. It's really developmentally critical time. And to promote mental wellness and not just treat mental health conditions or disease in this really beautiful preventative way. And this developmental process of developing skills over time is a part of a framework that we call healthy mental and emotional development. And key to this healthy mental and emotional development framework is the power of safe and stable relationships and nurturing relationships to undergird that developmental process. So, next slide, please. So this wording, healthy mental development, is really intentional because this is a lifelong developmental process of building strengths and skills over time. Children need to learn how to form relationships, communicate, manage their emotions and behavior, regulate their attention and their impulses. Okay. And when we focus on children's healthy mental development, we think about strategies to help them to build these really important skills across their lifespan. So this starts prenatally, goes through their earliest years, through the preschool and school age years, and on up through adolescence as well. But all along through this developmental process, there are a number of factors that can influence whether this process goes well or whether it goes sideways. Let's move to the next slide. There are a lot of factors that can influence this process of healthy mental development. First of all, there's a lot of individual biology and genetics going on. Even within the same families, you'll see different siblings who just seem to have different responses to similar stressors. So some are more susceptible to others than others. Then there's what's in the environment and the child's own experience. Have they been experiencing trauma, adversity, and stress? Do they have positive supports and supportive relationships in their lives from their family, from friends, from other people in their environment? What's happening in their community and in the broader environment around them? This can really help to determine the course of this developmental process, whether it becomes healthy or otherwise. Next slide, please. Most of us have heard of adverse childhood experiences, or ACEs, like child abuse or neglect, exposure to family violence, parental substance abuse or mental illness. And I think most of us know that you don't have to wait to be an adult before ACEs start showing up in your health. So kids exposed to 4 or more ACEs, you can see here, double the odds of asthma, 5 times the odds of an ADHD diagnosis or developing depression, and 4 times the odds of developing depression, 32 times the odds of any learning or behavior problem. And so that makes it really incumbent on us to be searching for these kinds of adversities when we're seeing mental health and behavioral health concerns in practice. Next slide, please. But we are in this work because we know that adversity is not destiny. And despite all the negative impacts that trauma can have, many who encounter this kind of adversity still go on to do really well, and they show great resilience. And all the scientific research on the factors that promote this kind of resilience, the single most common finding is that children who end up doing well have had at least one stable and committed relationship with a supportive parent, caregiver, or other adult. Next slide, please. And so this brings us to positive childhood experiences, because these positive experiences matter just as much as negative ones do. And even in the presence of ACEs, these positive childhood experiences were associated with lower odds of poor adult mental health outcomes. And so you can look here and just see a lot of things that really have to do with relationships. Being able to talk with your family about your feelings. Let's go ahead and click next so that people can see this. Feeling that your family is standing by you during the hard times. Having non-parental adults who really take a genuine interest in you. Let's click on to the next, please. Thank you. Feeling safe and protected at home. Being part of cherished community traditions and feeling like you belong in high school, have some friends who support you. These kind of positive experiences, even in the presence of adversity, can really tip the scales. You can move on to the next slide. And these childhood experiences actually get embedded in our biology. They can change brain architecture, change the way our bodies regulate physical stress responses and susceptibility to disease, for better or for worse, and really affecting health and life trajectories for many years to come. So safe, stable, and nurturing relationships form like this buffer for adversity, and they're so important to the healthy development of children that the American Academy of Pediatrics actually stated that safe, stable, and nurturing relationships are biological necessities for children because they buffer from stress and proactively build the skills that are needed for resilience. Next slide, please. And it's all about relationships. Safe, stable, nurturing relationships really form the cornerstone of this healthy mental and emotional development framework. So in addition to healthy mental development being this developmental process, we now come to this next key principle, which is that of relational health. So relational health is the capacity to develop and sustain safe, stable, and nurturing relationships. And so these kinds of relationships really help to dial down the level of stress from toxic to tolerable and help kids to develop skills that promote resilience. And the key to this are responsive interactions between children and engaged and attuned adults. So infants and young children learn how to manage their own distress and regulate their own emotions and behavior through the attuned and comforting actions of their parents. This process is called co-regulation. So think about like hugging somebody who's distressed, or hugging somebody when we're distressed, and just finding comfort in the calm and available and caring presence of another person. This is co-regulation. And this is how children learn how to manage distress, form trusting relationships, communicate with others, and to manage their emotions and behavior. This all happens in the context of that critical early attachment. So throughout childhood, through all those developmental stages we talked about before, these kinds of caregiving, attuned caregiving interactions promotes the social skills and the communication and regulation skills and executive functioning skills that children need to thrive in any environment despite adversity. So relationships are so important that I once heard a trainer tell me that we should think of them as a vital sign, along with their height and their weight, their blood pressure, their heart rate. Look at the relationships in the room, and you can see a lot about that child's health and where they're going. Next slide, please. So finally, another key cornerstone in this healthy mental development framework is trauma-informed care. So promoting healthy mental and emotional development in children requires us to understand just how common and widespread trauma and adversity are in the lives of children, and to practice trauma-informed care, which involves recognizing and responding to trauma and adversity when we see it. So once again, relationships really are the key to trauma-informed care also. Not only this relationship between like the parents and caregivers and their children, but also between us as healthcare professionals and our patients and their families. Trauma-informed care fundamentally is relational healthcare. It involves moving away from judgment towards curiosity and empathy, no longer asking what's wrong with you, but what happened to you and what's right with you or what's strong with you. Next slide, please. I think a lot of us have this moment of fear, though, truth be told, when we hear some pretty intense disclosures happening in the room, whether it's a traumatic experience or really tough behavioral mental health concern going, what do we do? What kind of meaningful help can we provide, especially if we haven't been trained as specialty mental health providers? Well, as generalists, we can still bring a lot of help, and HELP is literally an acronym that stands for hope, empathy, language and loyalty, permission, partnership, and plan. It's bringing hope into the room by recognizing the strengths that the families are bringing. It's listening with empathy and leaving judgment at the door. It's paying attention to our language and moving away from clinical language towards the language that's preferred by our own patients and families, and expressing loyalty, saying, you are not doing this alone. It's asking permission before we go to the hard places and talk about sensitive topics. It's building up a partnership with our patients and families and co-creating a plan together with them. One or two next steps that can help make some progress towards some shared goals. Next slide, please. So common factors come from psychotherapy. There are many different kinds of counseling and psychotherapy out there, like CBT or motivational interviewing or family therapy, and they all have their distinct uses and their specific tools. But there are some common things that they share, and a lot of these have to do with therapeutic communication skills, or how you engage and talk with and listen with your patients and families. And these communication skills help to build this all-important therapeutic alliance, because this relationship, again, relationship with the patient and family really is what facilitates healing and well-being and hope. Up to half of the impact of psychotherapy might actually come from this therapeutic alliance. And guess what? You don't need to be a therapist to use these common factors and to communicate in a more effective way. And this kind of communication can really help to address some of the ambivalence, mixed feelings, some of the anger, even the sense of hopelessness that we sometimes encounter in the room. Really important things towards making progress. Next slide, please. So I personally came into this work because I became convinced it was a real opportunity in pediatric primary care to come around children during these developmentally critical times. Because we're seeing them often for checkups, especially in those first 3 years, or those sick visits, as well as those well visits. And we develop partnership and we develop relationship with families over time. So there's a real opportunity here then to get to know the kid, to get to know the family, and to partner with them as that brain is developing, as the body is developing, as the foundations for either healthy mental and emotional development to happen, or to help protect kids from the potential risks that may be surrounding. Next slide, please. So what exactly is our role as pediatric primary care providers? And how can we promote healthy mental and emotional development in our patients? So this goes well beyond diagnosing and treating recognizable conditions like anxiety or depression or ADHD, as important as that is. And honestly, most of our CalMap webinars, it was really here at the top of this pyramid. It's really about treatment. But primary care providers have this opportunity to do the stuff here at the bottom, primary prevention or universal health promotion. Vaccines are the primary example here. You give this to everybody to keep them healthy. The closest thing that we have to vaccines in behavioral pediatrics is parenting support, supporting parents in this important work of relational health and attuned and responsive caregiving. That's primary prevention. Moving up, secondary prevention, early identification and intervention. This is developmental screening. This is screening the parents for postpartum depression, screening adolescents for depression, and identifying the issues early, trying to prevent small problems from becoming big ones by intervening early, or preventing risk factors, big risk factors, from becoming diagnosable conditions later. So long before a specialist ever sees a kid, we have the opportunity to do a lot of mental health work in a really profound and meaningful way. And so with this, I'd like to hand the virtual mic over to my colleague, Gina Lewis, who will be sharing about some really exciting tools and frameworks to help us to develop strong therapeutic alliances with our families and to promote relational health in primary care. Gina.
Thanks, Joanne. Well, I want to start out by saying that thank you so much for including me in this. I definitely have felt over the last 5 years, and maybe some of you have felt kind of a tremendous burnout around the practice of medicine. And some of the things that have brought me back to the joy of practicing medicine is early relational health. And I want to share 2 tools with you today that have really changed the way that I practice. And I'm now starting to teach the residents about this. And I'm finding it very interesting because it really is like unteaching ourselves the way that we were taught in medical school to think and to do, as opposed to listen and be partners with families and patients. The first couple of slides is about the circle of security. Maybe some of you have had the chance to take this training. It is a parent training that is around understanding what secure attachment is all about. This slide is a summary slide that in the training is gone into in great depth, and it is deceptively simple. I want to kind of break down some of it for you so you have an understanding. You can also go to the Circle of Security website and watch some really great videos And if you're interested in signing up for a training, this is an international organization, and it's not just doctors they train, it's lots of people who are involved in the lives of children, including parents and other kinds of caregivers and therapists. But in summary, the Circle of Security is about the idea that all of us, not just children, but all of us need to have a secure base and a safe haven for us to learn, explore, and be brave. We want children to be able to go out and explore. And we want to be able to share the joy that we see them experiencing and delight in the joy that they take. They want us to watch them, to make sure they're okay, to make sure they're doing it the right way, to help them, and just to see that we are happy with what they're doing. And often they need us. They skin their knee, they aren't sure about something, they get scared by something, and they need to come back and know that they're always going to have a safe haven with their caregiver, that caregiver is going to protect them and comfort them and help them to understand their emotions, not just happy, sad, angry, right? There's a lot of nuance and emotions, and we need to have our caregivers help us to understand what that vocabulary is and what we're feeling. Next slide. The other part of Circle of Security is that the parent is always the one who's the bigger, stronger, wiser, and kind parent. Now, that might seem like this is attachment parenting to the extreme, but that is not, it doesn't mean that we're not disciplining. It doesn't mean that we're not creating boundaries. In fact, we are. We are creating boundaries. Whenever possible, we want to let children do what they want to do. That's how they're going to explore. But there are times when we need to take charge. And this training helps parents and caregivers recognize when those moments of rupture, of need come into play, and when, as a caregiver, it's time to step in and create a boundary. And boundaries can be given in a kind way. They don't have to be given in a demeaning way or a physically violent way. We also know that relationships, all relationships, and including relationships with a parent and a child, aren't always perfect and shouldn't be perfect, and that ruptures happen and issues happen in relationships. And when that happens, we repair, and the parent learns how to apologize for their outburst and name what happened to the child and reconfirm that they love the child deeply and that the next time we're going to do things differently. One of the things that I found so satisfying about this training is how universal it is to all relationships. It's not just about the parent-child relationship. It's about my relationship in the room with parents and the child. It's about my relationship with my loved ones. And really being aware of what's happening with the provider-family relationship has brought a whole new dimension of being a pediatrician. So I highly recommend checking out Circle of Security. Maybe it's something you want to pursue more. It's something that I now give to parents, especially parents of young children. The website and a little bit of background, that picture, so that they can look at it for themselves and understand that you don't have to be perfect. You're enough. You are enough. And just understanding that things happen in relationships, and trying to repair and to let your child know that it's okay when things don't go perfectly, and there's a way forward with that. So we'll go on to the next slide, please. The other tool that I want to spend a little more time on is a program called Facilitated Attuned Interaction. You may know about the Fussy Baby program through Early Intervention Service. And if you've, Fussy Baby is also a national program that you may have experienced in other places. The Facilitated Attuned Interaction is something that was taught as a way to help people that are working with children and families communicate in a more empathetic way. And there are two tools that are used that I'm going to go over today. I wanted to show you both. There's the fan, which is the first image on your left, and that's really a communication process. And there's the arc, which is on your right, and that's the structure of contact. Again, we're teaching our residents this rubric, and while it's a simple concept of doing more listening and less talking, and letting families and patients lead the visit, it is completely out of comfort zone because we're taught to think and do in medical school and residency. We're not necessarily taught to listen and to follow the lead of families and patients. And that's really what this facilitated attuned interaction helps you to do. Now, that might seem like you're giving away your power, and yes, it's true, you are, but you're not giving away the visit, and you're not giving away your agenda, and we'll get into a little more depth as we do some examples through the next few slides. So let's move on to the next slide. So here's another bigger picture of the fan. Hopefully you can see that whole fan diagram. There is the parent's true concern at the center. How many of us have been in a visit where we read the room, read the body language, and realize kind of we're missing the mark. We're kind of like, missing each other in our interaction with parent or caregiver. And maybe you leave that interaction feeling like a little unsatisfied as a provider, like thinking to yourself, well, maybe there was something else that they didn't get to share with me. The wedges of the pie go around that parent true concern and help us think about the different feelings that may come up, the different things that may come up at any point in the visit. The calming wedge, which we'll talk about a little more, is for us. It's for us to be aware of what we're bringing into the room and how we are while we're sitting there. Are we fully engaged? Are we thinking about the last patient and the prescription we forgot to write? The feeling wedge is one of the most important areas of this tool. It's this idea that while we come in with a whole agenda of things that we want to talk about, the family has also been waiting for us. They may have been waiting in the room a couple minutes, but they've been waiting for months with a list of things to talk to us about. And jumping into our agenda before they're able to give their agenda sometimes can be very disappointing to parents and families. The thinking collaboration wedge is where we have the opportunity to work collaboratively with a family, collaboratively to create, to think about what's going on and create a plan together. Doing, which we're very good at, is something that I often will skip right to. And sometimes parents are ready to just skip right to that themselves. My kid's starting school, they need the MMR vaccine. I want to do it, doc, let's do it. And sometimes that's true. Most of the time it's not. But there's a place for it in the visit. And creating that therapeutic alliance, to me, is probably the most important thing, whether or not I get to meet all of the agenda items that I had coming into a visit. And then finally, the reflection piece where we can really look at how a parent was in the moment in the visit with their child, and reflect back with the family about how their parenting is going and what they can do in the future. Let's move on to the next slide. So we said it before, mismatch is the norm in all relationships, even the best relationships. And so 70% of the time we're missing each other. And 30% of the time in a great relationship, we're getting it right. And that's okay, and that's normal. And so sometimes in a room, we might have a mismatch, and we can stop ourselves and say, time out. I feel like this visit is getting away from us, and I think you might have something else you want to address. Are we addressing everything today that you want to address? And we'll get into that a little bit more. Next slide. So I want to talk a little bit more about empathic inquiry, the feeling wedge, with an example of a patient that I'm sure we've all had, if not today, maybe yesterday or the day before. A child who's coming in for a school physical, and the first thing the parent says as you walk into the room is, I don't want him to get any vaccines today. And I don't know what that makes you feel. And we'll talk about mindful self-regulation in the next slide. But before we talk about that, let's talk about how we can address that. I'm sure you all have beautiful spiels when somebody says something like this to you. And the invitation of this training is to be curious. I don't want him to get any vaccines today. Tell me more. Tell me more about your feelings about vaccines. And I have to kind of lean back. I have to put my hands under my legs. It's my little sign to myself to shut up and listen. And I think that is a very surprising sentence coming from a doctor sometimes. Tell me more. We're in a rush to get from room to room. We have 10 to 15 minutes to see a patient. It's not enough time. We all know that. We know it, the patient knows it, and they feel it, and they feel our body language. So leaning back, asking them to tell us more, makes us more efficient. It might not seem like it in the moment. You still might feel internal anxiety around that, but that is a great way to open-ended question, open it up, and create that opportunity for a therapeutic alliance where some people feel like they're being heard for the first time in a doctor visit. I've had people cry when I ask them, tell me more, and say to me, nobody's ever asked me to tell them about why I don't want vaccines. I know none of you do that, but I mean, I just have had such a different experience kind of coming in with that ability to kind of slow myself down. So let's move on to the next slide. I want to show you a little video that I might need help turning on. This is from Inside Out, and it's a little snip with joy, sadness, and bing bong. And it basically is a lovely demonstration of when toxic positivity, have you heard that one, gets in the way of empathic inquiry and listening.
Riley can't be done with me.
Can people hear that? I'm not sure. Okay, good.
Hey, it's gonna be okay. We can fix this. We just need to get back to... Which way to the train station?
I had a whole trip planned for us.
Hey, who's ticklish, huh? Here comes the tickle monster. Hey, Bing Bong, look at this.
Joy just wants to she wants to fix it and move on.
Station, and we all go there. Won't that be fun? Come on, let's go to the train station.
I'm sorry they took your rocket. They took something that you loved. It's gone. Forever.
Sadness. Don't make him feel worse.
Sorry.
It's all I had left of Riley.
I bet you and Riley had great...
Sadness is going to take 1 minute of her time to listen to Bing
Once
Bong.
we flew back in time, we had breakfast twice that day.
Sadness.
It sounds amazing. I bet Riley liked it.
Oh, she did. We were best friends.
Yeah, it's sad.
I love that he cries candy.
I'm okay now.
And once he's heard, the relief of just being heard.
This way.
And now he's ready to go to the train station. And it took 1 minute. So next slide. Yeah, it'll just keep playing over and over again. Okay. Oh yeah, let's go back to mindful self-regulation, I think. Oh yeah. So I wanted to say a little bit of just about my own self-talk when somebody says, I don't want to vaccinate today, or there's kind of a mismatch. And I sometimes can prepare myself and know the family and know how they're thinking ahead of time. But sometimes it's the first time I'm meeting somebody and it like catches me off guard a little bit. And I like have a terrible poker face. So I really need to like kind of reel in my nonverbal cues. But I'm talking to myself like, okay, I get it. And I might be frustrated that I'm gonna have to do, some discussion around vaccine safety and the importance of that. But I'm also like just giving myself a break. It's okay that I'm frustrated. Just take a breath and kind of control thyself and then kind of move on with the conversation, and then we can move to the next sentence, the next the next slide, and then I am ready to say I hear you. It's okay. I don't have to agree. I'm just listening with acceptance to how they feel and holding, validating, and then when they're ready, I can explore and move to the next part of the visit, and we can go to the next slide. And that's around collaborative exploration, understanding how the family's feeling and seeing if there's a little place to kind of come in and talk about this more. So you may say, can we talk about this a little bit? What is it about the vaccine that's making you nervous? I know you're here because you want him to start kindergarten. Tell me a little bit more about what you think we should do. And so this is more about letting the parent guide. They have the answer so much of the time, and letting them kind of take back control over what they think we should do. And that really builds that therapeutic alliance. And next slide. And then next is the doing wedge. So this is where instead of saying he's due for the MMR, he's due for the Tdap, let's go. You may say, especially if you know the family, you've talked about the Tdap vaccine before, or you've talked about the MMR vaccine before. We've talked about the fact that he needs it to enter school. Would you consider doing that today? Sometimes I'll say something like, with this same example in mind, I'm your health advisor. You're the parent and you get to make all the decisions. And I often see like just a 180-degree switch, body language, relaxation. I'm giving them back the power. And that's when they're able to say yes. Not all the time, but often. That, kind of power differential really sets things up for feeling unsafe. And when I give that power back, there's some safety that's handed back too. And that's a capacity building moment. That question of, would you consider that today? I'm dropping the idea and exploring it. I'm not saying we have to do it. We're just exploring together. And that often is a real connection, a real connecting moment. Next slide. The other piece of facilitated attunement interaction is this arc, which is set up to be kind of the process of the visit and really helps when you think about how I usually think about a visit with the beginning, middle, and the end. But I want to just bring back the idea that we're trying to understand the parent and the patient's experience and their agenda, and share the power and collaborate. And really, the end of a visit can be a wonderful moment for supporting what you see in the room around what the parent feels is the most important thing. Sometimes I think that I am a well-educated barista because I am in the service profession, and I know that if I don't have a therapeutic relationship with a family, they're going to go see somebody else. They're here to get something from me, and if I'm feeling like I'm not meeting them where they need, sometimes I'll interrupt the visit and I'll say, "Are we getting to everything you need today?" So the beginning, middle, and the end, I would say the middle is one of the most important times, especially if you feel like you have a mismatch between the family, the parent, the patient, and yourself, to reset and find a way towards the patient, parent, family's agenda. Next slide. Some scripts that you might think about using for your own self. How am I? Are you as the provider? Are you harried? Do you have 3 patients waiting? Do you know this family and dread going into the room because you've had interactions that have been really difficult? How are you going to hold yourself compassionately when your blood starts to boil when they ask you a question that is annoying to you, just to be really honest and direct? And what do you need to be fully present? Do you need to huddle with your MA or your nurse so that you make sure that you've gotten everything done with the patient before? You have a good idea of how much time you have to work with this patient before you enter the room? And next slide. And in the beginning, what has helped me a lot is, of course, being able to scrub my charts and know my patients ahead of time. And being able to come in and say, I looked through your chart and I saw that visit with the ear, nose, and throat. I'm wondering what it's been like for you since I saw you the last time. You've had a lot of appointments. You've had a lot of things on your plate. What's it been like? Open-ended questions. What would you like to talk about today? There's always a moment where you can add in. If you're feeling anxious and you know that you have a bunch of things that you'd like to address with the family, you can add it in the beginning. I have a few things on my agenda too that I'd love to talk about, but I want to know what you have to say first. Let's start with what's on your mind. Next slide. And then as you're taking this history, you can say, as your partner, I just want to check in with you. Are we getting to what's most on your mind today? And then here's where you can drop in, again, your agenda. I'm wondering if we can take some time to talk about the vaccines. I know we've talked about them before, and I know he's starting school tomorrow. May we spend a few minutes talking about that? You have to do a little bit of the work of listening before you can get to that drop and explore moment. But there are places within the conversation where you can drop those ideas in. Next slide. And I think that, again, at the end of the visit is a great time to reiterate what you're observing in the moment. We're modeling what we are hoping that parents will do with their own children, listening to their children, reflecting with their children about what they're feeling, their successes, their struggles. We're modeling that with our relationship with them. And you might call that out. I really enjoyed watching when I handed the book to Johnny. He ran right to your lap. He opened the book and he was ready for a snuggle and a book. It shows me that you have a loving relationship, that you're reading at home, that you're responsive to what he needs when he needs it. And I really appreciate that about you as a parent. Next slide. And then after a visit, thinking about what it was like for you to engage. Was it a match? Were you able to find that? connection with the family, with the child. And if not, right, there's always opportunities to have follow-up. And sometimes a family might be talking for a long time and you realize that maybe you get a knock on the door and you realize, okay, I've been listening and I've been empathic, but I have 3 other patients waiting. You can always say, I really appreciate what you've shared with me today, and I wish I had more time to spend with you. Would it be okay if we talk about some of those things at a follow-up, in a follow-up telehealth or at another appointment? I know you need these vaccines for school. May we interrupt our conversation to do that and set up another time to talk? So there's I'm sure all of you are very skillful at this. I am not, and I'm practicing this every day. I feel like the practice of pediatrics is an unfair game that we are set up to fail with 72 check marks from the AAP Bright Futures guidelines that none of us will ever get through in a 15-minute exam, especially when mental health issues, parenting issues come into play. And that's why I see your chat. It's inadequate, right? It is inadequate. And I think that I know that there's research behind the fan, and that the practitioners who are using it are finding that they are actually more efficient. That once they kind of let some of this happen with a family, taking back the control, listening to families, that that subsequent engagement is more efficient. There's more trust, and that the provider themselves feels like they're able to address some of the agenda items that they have on their list. Next slide. I think I'm turning it back over to you, Joanne. But just a final thought, that we really want to treat the parent as you want the parent to treat the child, right? With respect and empathy and curiosity. And the parent, I think, will see that and feel it and be able to trust us more. You know, it wasn't by accident that we used this example of vaccination. You know, we're in an era where people don't trust us. How do we win back that trust? How do we feel like we're able to continue in this profession and do what we know is so important to protect the health and well-being of children? Well, we have an uphill battle, but I feel that these 2 tools have dramatically increased my ability to regain trust with families. And I'll turn it back to you, Joanne.
Thank you so much for that great description. Let's move on to the next slide, please. This is a bit of a summary slide for us here. If we can take away nothing else, is that relationships really are the key to resilience. They are the cornerstone for helping to ensure healthy mental and emotional development in our patients. By listening and being with our patients, by offering help or these therapeutic communication skills, and thus supporting safe, stable, and nurturing relationships. One of the takeaways for me from Circle of Security training was this idea of being with. This is like this emotional availability to another person that's calm and that isn't overwhelmed. It's a state of mind. It's a presence that you bring more than anything that you particularly do. And that sort of like presence of mind and that sort of kind of presence has actually really changed the way I think about pediatrics and approach pediatrics. And I feel like this is part of what it means to provide trauma-informed care, to promote healthy relationships in the lives of children, and to help promote that healthy mental and emotional development that we are about. Again, forming the foundations for a child's future life. I see that we are up in question and answer time, and there is this great question here from Dr. Mailer that really speaks to the reality of just really brief visits and too much to do, and a lot of big feelings in the room at times. And I don't know that we can fix all of that, and I think this checklist mentality honestly is part of the problem. And I fully recognize that what's being talked about here, what we're talking about here, is a bit of a culture change in medicine that really is about that thinking and that doing and just getting stuff done. And this is how our health systems are arranged, and this is how our electronic health records are organized. I don't think we can do this perfectly. I don't think the aim is perfect. But I think to be able to drop nuggets and little bits where a patient has felt heard and seen and listened to, where we can be with folks and bring a little bit of that presence, maybe check off a few of those boxes. But importantly, to form that therapeutic alliance with our families, I do believe that we actually get a lot more done, and we will eventually be more effective in the work that we're trying to do. And so, yeah, I agree. There's some real conflicts here, and it's about what are our priorities going to be and how do we want to practice medicine. Gina, I don't know if you have other thoughts on this particular question, or if there are other questions that come up.
I mean, of course, I feel that stress too, and our QI and everything else about reimbursement really like sets us up to not uh, uh, to do this model of a visit. And it's very, very challenging for the residents. It's super confusing to come in with a templated note with the 72 things that they have to check off and then ask them to just sit and listen. That's very counterintuitive. So yeah, it's hard. And I found that for the majority of my patients, I'm able to get my checklist. But where this really helps me is with families who don't trust. They don't trust the healthcare system, and they don't trust me as part of the healthcare system. That's where I really find this tool to be the most helpful.
Thank you folks so much for the talk. I find it really, really meaningful and really like inspire a lot of ideas. I think one thing kind of along the line that Dr. Miller was asking, I was wondering if there, from your experience, is there any strategies to engage leadership to build that infrastructure to encourage PCP to be able to do this type of work? Because like Dr. John was saying, and that this is a cultural shift, so it's probably not going to happen overnight, but is there any strategies that you have found helpful?
Oh, that's such a hard question. I think, okay, let's go back to the vaccine example, right? I mean, I think we all have pressure to vaccinate a bigger percentage of our families. And there really is mistrust around vaccines. And so, nationwide, our vaccine rates have gone down. So if that's a priority to you to get those QI numbers up, I find this method to be very helpful in regaining trust. And what we have done is we've increased some of the number of visits so that we have more opportunities to vaccinate. We still are able to use telehealth, video telehealth, and telephone telehealth. And I don't know about the rest of you, but that's come in very handy for some of these longer conversations that can interrupt an in-person clinic visit. So sometimes I'll kind of put that off. But in terms of like changing the mind of the business end of medicine, I need another training for that. because because I don't think that's changing anytime soon. But I do think that I know that Joanne and others are working with the AAP to change the way we think about Bright Futures and the Bright Futures guidelines. And I think that will be a trickle-down effect for policy and CHDP guidelines and the rest that hopefully will increase the amount of time we're able to spend with patients. Joanne, you have a big job.
Anyway, I see that we are at the top of the hour, and so we'll let people go. This year, we are doing credit a little bit differently. We are trying something a little bit differently, so we don't have a QR code to share for today. If this new system doesn't work, you may be seeing QR codes in the future. But thank you all for coming to the first webinar of the year. We are very happy to see you here. We hope to see you back. The next webinar will actually be the first Friday of September, and I believe we will be talking more about trauma and resilience. Hope to see you then.